Approximately 70% of patients who survive the immediate impact of an explosive event present with at least 3 different types of severe injuries simultaneously. When an explosion occurs inside a building, a bus, or any enclosed space, the geometry of that environment causes the energy waves to reflect and compounding. In these scenarios, the polytrauma rate exceeds 90%. Familiarity with these specific trauma patterns is no longer an exclusively military requirement. General surgeons in civilian practice routinely face blast trauma from industrial failures, ruptured compressed gas cylinders, and the violent thermal runaway of commercial lithium batteries. Standard penetrating or blunt force trauma typically presents with predictable wound channels or localized crush zones. An explosion, however, unleashes a simultaneous multi-vector assault. A single patient will often present with penetrating shrapnel, heavy blunt force decelerations, and deep thermal burns. Medical doctrine classifies these blast injuries into 6 distinct categories. Categories 2 through 6 cover everything from projectile trauma to long-term neurological decline. But it is Category 1, primary blast injury, that dictates immediate survival. These injuries are caused exclusively by the pressure wave passing through the body, destroying internal anatomy while leaving absolutely 0 marks on the skin. Relying on standard visual trauma assessments will lead to critical diagnostic failures. Treating these victims requires surgeons to use the physics of the explosion to mathematically predict the hidden organ destruction. Explosives fall into 2 mechanical categories. Low-order materials like household gas or gunpowder deflagrate at subsonic speeds, mostly producing fire and localized mechanical pushing. High-order explosives like TNT or C4 detonate. They convert their mass into a supersonic pressure wave, traveling up to 9,000 meters per second. This graph maps the mathematical signature of that high-order detonation, charting atmospheric pressure over time. This is known as the Friedlander waveform. It begins with the positive phase. Ambient pressure experiences a sudden, momentary, and massive spike, often reaching hundreds of pounds per square inch in a fraction of a millisecond. Immediately following the peak, the pressure violently drops below normal atmospheric levels into the negative phase. This acts as a localized vacuum. While it is less intense than the initial spike, it lasts 5 to 10 times longer. If we take the peak pressure and multiply it by the duration of that positive phase, we define a metric called impulse. Peak pressure determines if a window breaks, but clinical data shows that tissue trauma correlates heavily with this total impulse. It is the sustained momentum of the wave, not just its highest point, that transfers destructive energy into the body. When this specific sequence, hypercompression immediately followed by a sustained vacuum, encounters human tissue, the wave passes entirely through dermal layers and systematically dismantles internal structures. The wave travels smoothly through solid, fluid-filled structures like muscle and bone. The destruction occurs when the wave hits an acoustic density boundary. These are anatomical junctions where dense, rigid, or fluid tissue abruptly meet an air cavity, primarily the lungs, the middle ear, and the intestines. Looking at this cross-section of an alveolar sac, we see the first mechanism of failure: spalling. As the high-pressure wave hits the boundary, it accelerates dense surface tissue into the lighter air cavity, spraying microscopic particles of the organ wall into empty space. Next is implosion. During the prolonged negative phase of the Friedlander wave, the heavily compressed air cavities are forced to suddenly and aggressively expand outward, causing structural limits to fail. Finally, shear force. Because tissues of differing densities accelerate at different speeds when struck by the wave, the connective junctions between them are torn apart by opposing physical momentum. At the cellular level, these 3 physics mechanisms shred the microvasculature. The result is massive, diffuse internal hemorrhage, occurring completely out of sight. Primary blast injuries occur specifically at these zones of acoustic mismatch. The internal density of the lungs and gut makes them uniquely susceptible to this type of internal structural collapse. This structural compromise results in blast lung injury, or BLI. It is the most common primary injury and the absolute leading cause of immediate death in initial survivors. Patients present with hypoxemia, hemoptysis, and extreme dyspnea. Chest radiography will typically reveal a distinct bilateral bat wing infiltrate radiating from the hilum, a direct visualization of severe capillary rupture. There is a persistent, dangerous myth that an unruptured eardrum means a patient was shielded from the blast wave. Clinical data proves otherwise. 18% of severe blast lung victims present with perfectly intact tympanic membranes. An intact eardrum rules out nothing. Below the diaphragm, gastrointestinal blast injury operates on a uniquely deceptive timeline. It primarily targets air-filled segments like the ileocecal region, and its incidence skyrockets in underwater and enclosed space explosions. It begins as a mild submucosal hemorrhage. Over the course of 4 to 7 days, that bruised tissue undergoes creeping ischemia, necrotizes, and eventually results in a full delayed bowel perforation. Because of this delayed timeline, medical protocol is absolute. Any victim of an enclosed explosion must be admitted for a minimum of 24 to 48 hours of strict observation and sequential fast imaging, regardless of how stable their initial vitals appear. In the context of explosive pressure, hemodynamically stable, walking wounded patients are often an illusion. They are harboring progressive, lethal necrosis. Category 2, or secondary blast injuries, are caused by shrapnel. Because these projectiles travel at high velocities, often exceeding 1,000 meters per second, they generate extreme temporary cavitation inside the body. The deep tissue destruction extends far beyond the visible wound track, demanding wide, aggressive surgical debridement of heavily contaminated tissue. Category 3 covers tertiary physical displacement. When the blast wave throws a victim into a solid barrier, the resulting blunt force trauma can culminate in traumatic amputation syndrome. Statistically, an amputation caused by blast displacement correlates with an over 45% incidence of concurrent blast lung injury. Category 4 encompasses quaternary injuries, environmental hazards like chemical exposures and thermal burns. These overlapping categories create severe clinical contradictions in the trauma bay. This split-screen model illustrates the most lethal contradiction, the ventilation paradox. Quaternary inhalation burns create progressive airway edema, mandating early intubation and high positive pressure ventilation. But primary blast lung injury requires a strict low-volume, low-pressure strategy to protect the fragile, shattered alveoli. If you apply standard positive pressure to a blast lung patient, the ventilator will force air directly through the ruptured alveolo-capillary walls. You will create an air vascular fistula, pumping lethal systemic air emboli straight into the left heart. Resolving this requires strict lung protective ventilation strategies, keeping plateau pressures below 30 centimeters of water, and placing the patient in the left lateral decubitus position to trap potential emboli. A second quaternary conflict occurs in the field, crush syndrome from heavy structural collapse. Prolonged entrapment fills ischemic muscle tissue with myoglobin, potassium, and lactic acid. Aggressive, high-volume fluid resuscitation must be initiated before the debris is lifted. If the rubble is removed first, sudden reperfusion flushes those toxic metabolites into the central circulation, causing acute renal failure or immediate cardiac arrest. Survival in explosive polytrauma is a careful balancing act. The aggressive treatment of one visible injury category can rapidly and lethally compromise unseen primary injuries. This timeline maps the hidden dangers of a blast injury across a critical 7-day window of decompensation. Hour 1 presents the immediate life-threatening airway complex, identifying blast lung, intubating for thermal burns, and preventing systemic air embolism. Between hours 24 and 48, we enter the critical observation window. This is where hidden submucosal hemorrhages in the gut reach a tipping point of internal bleeding. From days 4 through 7, the delayed gastrointestinal ischemia fully manifests, creating the high-risk zone for complete bowel perforation and acute sepsis. Concurrently, we see the quinary effects. Massive cytokine release from the destroyed tissue triggers systemic inflammatory response syndrome and profound trauma-induced coagulopathy, requiring sustained damage control resuscitation. Definitive care for blast victims does not end when they are stabilized in the initial trauma bay. It requires a relentless, proactive hunt for evolving pathologies over the course of an entire week. Beyond the physiological challenges, the attending surgeon must also navigate the severe operational realities of the event itself. You must suppress standard clinical tunnel vision. The shock of an obvious, gruesome amputation will instinctively draw your complete attention, but it cannot distract you from identifying the silent, deadly, lethal tension pneumothorax. Always acquire the physics history of the event. Knowing the explosive type, the patient's distance from the epicenter, and whether the space was open or enclosed allows you to mathematically predict the internal damage pattern before the stretcher even reaches your bay. Finally, in civilian mass casualty incidents, scene security is paramount. Intentional bombings frequently utilize secondary explosive devices, specifically timed and positioned to target first responders and arriving medical personnel. You do not advance without tactical clearance. Blast trauma strips away the predictability of conventional medicine. It is applied physics executing multi-system destruction. Defeating this invisible enemy demands strict intellectual rigor, absolute anticipation, and the discipline to treat the mechanisms you cannot see.